Assalamu alaikum. I hope so. You all are doing very well and you are fine. And today we are back with another lecture of oral surgery. And today's lecture is basically on the salivary gland pathology and diseases. And we will basically discussing about the diseases. So let's start with the name of Allah Almighty. Now, the classification of diseases of salivary gland include basically the inflammatory sialadenitis, which comes in the first. It is a basically inflammatory condition, and in which is basically due to the infection of salivary gland. It can be either viral infection or it can be either due to bacterial infection. The both either of the cause can be led to the inflammatory sialadenitis. However, there is another important disease which is known as obstructive disease, and under the heading of obstructive disease includes salivary calculi, or in the easier term we call it shallow liths, which means that salivary stones basically. So either it can be inflammatory sialenitis, which could be due to the viral infection or bacterial infection, and it can be also obstructive disease, which is more commonly known as the saloliths or salivary calculi, salivary gland stones. Now it could be either traumatic lesions as well, which includes extravasation and retention cysts. We will discussing in detail in the next slides. And it could be either necrotizing sialometaplasia. This is an important term and a traumatic lesion, because a lot of questions can come in exam about the from the traumatic lesions. And then there is cell adenosis. Then we have Sjögren's syndrome. This is an all-time favorite syndrome of the most of the examiners, and a lot of the questions do come in as a UQ or SEQs in the exam from it. And then there are salivary gland tumors. So these are some of the classifications of diseases which the salivary gland can have. First, we will talk about sialadenitis. So, what is basically sialadenitis, uh, and how it is presented? It could be either due to the viral sialadenitis, or it could be bacterial sialadenitis. However, viral sialadenitis is known as mumps as well, because it is due to a viral infection, and it is also called mumps. However, there is another sialadenitis which is due to bacterial reason, and it is called bacterial sialadenitis. The sialadenitis, which will be due to viral infection or viral any virus, it will be known as mumps. Why? Because it is caused by the paramyxovirus. So do remember this term, that viral sialenitis is also known as mumps, and the mumps is caused, and it is basically caused by the paramyxovirus, because it can come in your MCQs as well. So now let's talk about transmission. Basically, it is transmitted through a direct contact with the infected saliva and by droplet spread. So the method or mode of transmission of this mumps or viral sialenitis is basically through the infected saliva or by a droplet spread. Okay, now the next thing that can come in your exam, and you can be asked in your Viva or MCQs as well, that what is the incubation periods of mumps or viral sialenitis? So the incubation period of the mumps or viral sialenitis is basically 2 to 3 weeks. Okay, now. In which age does it commonly occurs? Basically, it occurs more commonly in the children's age between 6 to 8 years. Do remember this as well, because it can also come in the exam as well. Now, this is a clinical presentation of a viral sialenitis mumps. It is not very much clear. Sorry for the picture. And okay, so how would a viral sialenitis patient present to you? Basically, he will be having fever as an infection a patient has. If you have a viral cold, you feel chills, so you will basically have chills. Then you will also present. The patient will also present with a headache as well, and there will be pre-auricular pain. Okay, it will be painful and non-erythematous swelling of parotid gland as well. Patient will present with you with the signs of a non-erythematosus swelling of parotid glands. Diagnosis would be done clinically as well, clinically, and how it you will resolve it. Basically, this comes in the exams. The UQ will be presented like a patient presented to you with fever, chills, headache, and pre-auricular pain with non-erythematous swelling of parotid glands. On clinical examination, it was confirmed that the patient has viral sialenitis. How will you manage the patient? So basically, you will manage the patient in this way. It basically resolves in 5 to 12 days, so no need to worry a lot about it. Okay, so we will give a sportive and symptomatic care In this way, we will give the patient antipyretics, analgesics, and adequate hydration. Antipyretics is given to resolve the fever matter. Analgesic is are given so that the patient feel uh, uh, relief from the pain, and adequate hydration because of these diseases. What happen that in the viral Sialadenitis, Sjogren's syndrome, or any viral infection, you may know that the fluids intake is very much less, and the patient becomes hydrated. So dehydrated. So adequate hydration is required. That will resolve it. And the best thing to resolve viral Sialadenitis is that you take adequate fluids along with the antipyretics, analgesic, and supportive and symptomatic care, and it will ultimately resolve into 5 to 12 days after onset. So do remember this on resolving days, because it can come in your MCQs as well. So now this is very important thing. Another thing, it can also come in the UQ as well. What are the complications of the viral sialadenitis? Basically, the complication of viral sialadenitis or mumps includes meningitis, pancreatitis, orchitis, or testicular atrophy or sterility. So it can cause basically meningitis as well. It can cause pancreatitis as well, and it can cause orchitis as well. Okay, so these are some of the complications it can lead to. Then we have bacterial sialadenitis. So basically, first we studied viral sialadenitis. Do remember the viral sialadenitis is also known as the mumps, and now we are studying basically bacterial sialadenitis. So basically we are studying sialinitis. First we discussed the sialinitis which was due to the viral infection, and which virus was causing basically mumps or viral sialinitis. It was paramyxovirus, do remember it. And now we are studying bacterial sialinitis. So basically sialinitis which may be due to bacterial infection. It can either present you with acute or chronic. Okay, so we will be discussing the predisposing factors. So, what are the major factors that can lead to bacterial sialinitis? Basically, it can occur into the elderly debilitated patient, the patient which are uh, older of age and are not very much in good health. Then the patients which are malnourished or they are deprived of nutrients. Then the patient who have chronic illnesses, we can see bacterial sialinitis in them as well. And the patients in which there is which they are rehydrated. So basically, in such patients, we can have bacterial sialinitis, and there are some other condition factors which can contribute to it. And xerostomia, as I told you earlier, immunodeficient patient, the patient who have salivary stones, salivary calculi, the patient who are of older age, especially of above 60 years of age, the patient who have undergone some radiotherapy or okay, and the patient who are having like Sjogren's syndrome. Okay, now microbial flora. So what are the basically causative agents which can lead to it bacterial sialadenitis? So basically the microbial flora includes mixed bacterial flora. The causative agent can be either mixed bacterial flora, and the most commonly staphylococcus aureus. So basically you should ask in the exam, you should know that staphylococcus aureus is the most common microbial the bacteria which could cause it, the bacterial sialinitis. Or then there are streptococci as well. Then there is anaerobes as well. Now coming towards the clinical feature, as you know that basically it is rapidly onset of swelling. There is rapid onset of swelling. There is tense. It is basically tense and non-fluctuant. You might see that there are erythemia. There is a lot of redness, and the patient will complain of pain as well. There will be purulent discharge from the ductal orifice or palpation of gland. Whenever you will palpate the gland, so you will see that there will be a pus discharging out from the ductal orifice like duct opening. And the patient who is having bacterial sialadenitis will be most probably having cervical lymphadenopathy. So do remember this as well, that he will present with a rapid onset of swelling, which will be tense and non-fluctuant. There will be erythema and pain. However, in viral sialadenitis, we see that there was non-erythematous swelling. So do remember this as well. And in the bacterial sialadenitis, there will be must cervical lymphadenopathy, and there will be purulent discharge from the ductal orifice or the palpation of the gland. So there will be a it will come under the heading of scenario. The patient presented with this. So you will need to know that it's either a viral sialadenitis or this is a bacterial sialadenitis. Okay, you can see in this picture basically the pus is being discharged from the ductal orifice. You can see here. So the pus, a patient who is presenting with a pustular discharge from ductal orifice and also is having cervical lymphadenopathy and is having your other symptoms and signs like erythema and pain and cervical lymphadenopathy. So you will know that he's suffering from the this bacterial sialadenitis. Okay. Now moving forward, how we will diagnose it. Basically, we will diagnose it clinically. In the on a clinical picture, you will see like the pus is basically being discharging from the ductal orifice. Okay. Now there will be leukocytosis, and there will be pus sample for the culture and antibiotic sensitivity. We will have a pus sample basically for the culture and antibiotic sensitivity. Now coming towards sialadenitis, you can see that here what happens when the perihelial is atrophied, there would be a salivary duct dilation. As in this case, you can see that salivary gland duct is basically dilated, and then there will be reparative fibrosis, and which leads to the irregular narrowing. You can see that it is ultimately leading to the irregular narrowing. So first happens like epithelial is being atrophied, which led to the salivary duct dilation, and then there is reparative fibrosis, which ultimately led to irregular narrowing. So, for the bacterial sialadenitis, what's the treatment? Basically, treatment includes supportive and symptomatic care. Do remember that we do supportive and symptomatic care. IV fluids are IV fluid hydration is basically given. We give antibiotics IV in the case of severe infection. We provide them with analgesic. Incisions and drainage is done because as I told you that pus was really charging, so we need to incise it and drain it as well. Excision of gland where it is irreversible. Functional impairment. If you see that it is basically irreversible and has impaired basically function, then you need to excise the gland as well. So you will proceed from the supportive and symptomatic care. Then you will give IV fluid hydrations. Then antibiotics will be provided. IV in the case of severe infection, analgesics for the relief from the pain and incision advantage as well. And ultimately you will lead to the excision of gland as well. So basically, what will be the complication? Complication will be that untreated infection can lead to the respiratory obstruction, septicemia, and death as well. So what happens basically, if infection is left untreated, it will either lead to the respiratory obstruction. You might not get enough of the respiration, and you it may ultimately lead to the in building of an infection in the blood, septicemia, or ultimately causing death as well. Now moving towards the next our category of the classification of salivary gland disease, which is obstructive disease, which include basically the sialoliths, more commonly known as salivary calculi or salivary gland stones. Okay, so in what happens in sialolithiasis or salivary gland calculi or salivary gland stones, that the incidence is basically occurrence is basically in males 2 to 1 ratio. It is occurs more commonly in the males than in the females. Salivary stones are more commonly in the males than the female. The peak incidence, the age in which it occurs more is basically 30 to 50 years of age. Okay, so uh, it happens mainly in submandibular gland. So basically, this can come in your exam as well. Please tell the incidence of the sialolithiasis, salivary gland calculi stones in the according to the age of the patient, like 30 to 50 years of age. You will tell, and in which gender, basically in males to female ratio, there is 2:1, and according to the glands as well. In submandibular gland, it is highest. Basically, it is 85%, and in the parotid gland basically it is 10%. You are saying that, and then in sublingual gland it is 5%. Divided gland basically so the subglandular glands, it can come in exam as an MCQ. Salivary stones are most commonly present in which type of gland? So you will answer will be your submandibular gland. Like in this case, you can see that there is a salivary stone. With the help of picture, you can notice that basically it is present below the tongue, as if this is a tongue, and it is basically present in the floor of the mouth. Okay, So now another question which can come in your exam as well: cause of the highest incidence of stone in submandibular gland. Why? What is the major reason that in submandibular gland there is a high incidence of stone? Because concentration of the calcium is twice as abundant in submandibular secretion than in parotid secretion. So do remember that concentration of the calcium, that level of calcium is basically two times higher in the submandibular secretion than in the parotid gland. So calcium is secreted there a lot, and there is alkaline pH of saliva. Basically, the pH is being alkaline, and a lot of anatomical factors also play an important role. Like there is low salivary flow rate and the area of stasis. Basically, the saliva cannot pass easily, and a very there is a less slow rate of the flow rate of the saliva. So there are the three reasons. This can come in exam, and you need to answer them in this way. Basically, the alkaline pH of the saliva contributes in the high incidence of stone in submandibular glands. Anatomical factors which involves like low salivary flow rate and the areas of stasis where there is a blockage, and concentration of calcium is higher in submandibular secretion than in the parotid secretion. So this is basically the answer. You can see that this is basically a picture which has been presented like histologically. You can say that if there is a this is a stone or calculi here, and this is the salivary gland, and these are the secretions basically. So basically it is blocking the secretion of the salivary gland into the oral cavity. Now, what is the pathogenesis of calculi? How this stone is being formed? How this calculi is being formed? So, formation of the nidus with subsequent layers of organic and inorganic material to form calcified mass. Basically, what happens that this nidus is basically formed by the subsequent layers of the organic and inorganic materials to form a calcified mass. And it includes the composition of cellular, which includes outer dense cortex and medulla. So there is a outer dense cortex. You can say that the cortex is very dense outerly, and there is a inner medulla. Basically, it is a composition of stone of salivary stone. So, what will be the clinical features of a patient with having sialolithiasis? Basically, the patient having the salivary stone or salivary calculi or sialolithiasis will show the signs of the acute painful swelling at the meal time. So, do remember that this can come in your exam, that a patient presenting to you with an acute pain swelling and is complaining that this his pain becomes enlarged on the meal times. What would be the reason? You should know that such a patient whose swelling or pain increases on the meal time, it can be due to the sialolithiasis. The patient will have other signs and symptoms as well, like erythema, redness. There will be chance of the lymphadenopathy as well. In the case of submandibular gland, the swelling in the floor of the mouth, as the submandibular gland is located in the floor of mouth, so you will see the swelling in the floor of mouth. Then when you will palpate the gland, palpation of gland shows no salivary flow or purulent discharge. So in such patient, there will be no salivary flow or purulent discharge. Do remember that in the case of your salal patient, there will be no salivary flow and there will be no purulent discharge as well. So how will you diagnose it? Basically, diagnosis is very much important, and like in exam, there it can come there. How will you diagnose a sialolithiasis or a salivary calculi or salivary stone? So you will be basically uh, diagnosing it on the basis of the clinical. How will you diagnose it clinically? By the help of biomanual palpation, you will palpate it basically biomanually. Uh, and with the help of radiographs, in the radiograph you will like have a OPG or lower occlusive radiograph. The best and the gold standard technique will be shallography, therapeutic for the mucus plus. Basically it is basically the therapeutic for the mucus plus because it removes the mucus plug from it. And then there is all endoscopy as well. So this is the radiograph, like if this is an OPG, and you can see that this is a stone here in the as shown in the picture. You can say that this is a now moving forward. So in the next picture you can say that this is basically a stone here which is present in the floor of the mouth here. Now moving forward, this is a salivary. There is a stone here. You can see in the radiolucency is being marked with the help of a marker here. So what we do for its opening stenosis with the help of a balloon tip catheter, we basically enter it, and you can see that there is stenosis in the second branch. This is a basic example, and then we remove this salivary with the help of a grasper, and the treatment includes, in the case of submandibular anterior stones, what happens, what you should do. Basically, you should do the milking of gland. Sialodoplasty and salivary stimulant should be given. In the case of posterior stone and substance of gland, excision of stones along with glands, extra corporeal shock take lithotripsy. So you can treat it on the basis of this location. If it's present anteriorly, you should milk the gland. You should give salivary stimulants. In child endocrinoloplasty, you can do it as well. In the case of posterior stones in the gland, you should remove the all the stone along with the gland, and you should do extracorporeal shockwave lithotripsy as well. So this is one of the clinical picture as well. You can see in this picture that there is it is being present here as well. And so with the help of the grasper, or you can say that we have removed it, the salolithiasis stone, and then we have placed like suture here. This is basically a salolith or a salivary gland stone. You can see the size of it very much. So the treatment includes if it's basically parallel salolithiasis, then you need to remove it in three segments. Like if stone is in the distal portion of Stenson duct, it is basically removed into orally by dilation of ductal orifice. If the stone is in the proximal portion of Stenson duct, so then you need to expose surgically. And if it is present in the substance of gland, like extraoral approach is required, and the removal of the superficial lobe of gland as well. So you can treat the parotid salivary in this manner. Then coming to the most important topic of our today's discussion is the difference between mucocele and granula. And mucocele is also two types, basically extravasation and retention, and necrotizing sialometaplasia. So basically mucocele, granula, necrotizing sialometaplasia, these come under heading of traumatic disease. Do remember this very much well, because it can come in exam that you can be asked like ranula is either traumatic disease or it is due to obstructive disease. So you should remember that ranula is a traumatic disease, and as well as mucocele and necrotizing cell metaplasia. So we will discuss about the mucocele. Basically, the mucocele is could be either excavation or retention cyst. Excavation is basically caused by the trauma to minus salivary glands. It could be either trauma to cheek or lip biting, or it can be on common sites are basically lip and buccal mucosa. So it could be either due to trauma or lip biting, and the more common sites are lips and the buccal mucosa. Cysts contain viscous saliva without epithelial lining. Okay, so do remember this as well, because it will be mucosal will be like there are basic this, pseudocyst as well without the epithelial lining. These are called extraphysician mucosal would be like having will be pseudocyst. And then there is overlining. So however, the overlining mucosa is basically thin, stretch, and appears as a blue gray. So the mucosa which is basically being traumatized in the case of mucocele will be thin, like very much less, and it will stretch and appear blue gray. So do remember this clinical sign as well. And then talking about the retention cyst, there are 20% of mucocele are two retention cysts, and it occurs in the older individual as well. So the 20% of mucoceles will be having like this two epithelial lining. Okay, so do remember this as well. So this is basically a picture of the mucus retention cyst. You can see that this is a basically a cyst, and this is having an epithelial lining here. And this is a picture of mucocele exhalation on lower lip. You can see in highly estimated that it basically it's present on the lower lip, and you can see that it is appearing in a gray black. You can say like blue gray basically picture here, dome shaped. How will you manage it? Basically, the management may include the diagnosis. You will first diagnosis by taking the history of the patient and clinical examination as well. Then you will treat it like excise the cyst along with the minor salivary gland. So first you will do like excision of the cyst, and then along with the minor salivary glands as well. Its recurrence rate is higher, so it can occur again. So basically, this is retention cyst. You can see there's a retention cyst here. There is a mucus plug is being formed here, even highly discriminated. So there is ranula. Ranula can be either of two types. It can be simple ranula, plunging ranula. This can come in your exam as well. MCQ in important is well. An examiner can ask you if there is a ranula, there is simple ranula, another is one is plunging ranula. What is plunging ranula? Basically, mucocele herniating through the mylohyoid muscle, resulting in a midline neck swelling. So plunging ranula basically is the mucocele which is herniating through the mylohyoid muscle, resulting in midline neck swelling. So it is basically the common cyst of sublingual gland. This can also come in exam that ranula is basically the common cyst of the sublingual gland, and this side is basically the floor of mouth. So it is more commonly occurring in the floor of the mouth. They are soft, fluctuant, and bluish. Basically, ranula is bluish, soft, and fluctuant. So do remember this as well. It is basically painless, but may interfere with the speech or mastication. It is painless, but it may interfere with the speech or mastication. Ranula, you can see that it is basically a large, bluish, translucent swelling in the floor of the mouth caused by the mucus excavation or retention cyst. It could either be due to mucus excavation or mucus retention cyst. This is one of the another clinical feature you can highly discriminate is that it is basically present into the floor of the mouth, bluish, fluctuant cyst. Like then it is they are removed and sutured it. How you will manage it? Basically, simple mass population most always led to the recurrence. Mass population with the antiseptic soak, gauze packing. Basically, mass population is done with the help of the antiseptic soak, gauze packing, surgical excision. You will do like a surgical excision with associated gland is more appropriate treatment. So you will like give a surgical excision to the associated gland, and it will be basically a more appropriate treatment. Mass ovulation with antiseptic soaked gauze packing can be also done. No, what is necrotizing sialometaplasia? So necrotizing sialometaplasia includes basically it is a benign cell-limiting inflammatory disease of minor salivary gland. This is also important and can come in the exam as well. And the common site includes posterior hard palate. So necrotizing sialometaplasia is more commonly located under the hard palate, posterior hard palate. It is a benign, self-limiting inflammatory disease. It is basically a benign condition. It is self-limiting. It dissolves on its own, and it is an inflammatory condition of the minor salivary glands. Like you can see that it is present more commonly on the posterior hard palate, and is benign and is self-limiting, resolve on its own, and it is an inflammatory condition of the minor salivary glands. So the causes includes it could be either due to a trauma, it could be due to the palatal infiltration of local anesthesia and ill-fitting there could be an ill-fitting denture as well, which may lead to necrotizing sialometaplasia, localized ischemic necrosis infarction in the area. There could be this is a reason, and there could be either diabetes mellitus or vascular disease. So the common causes include like either trauma, palatal infiltration of local anesthesia, either an ill-fitting denture, diabetes mellitus, or vascular diseases. These are some of the common causes of necrotizing uh, Sialometaplasia. Now, the clinical features basically include common in the it can be either more common in middle age, like at age adult female. It will patient will present with you a painful deep crater-like ulcer on the palate. You will see like there is a deep painful crater-like ulcer on the palate, 1 to 4 centimeter in size. Then there will be local paresthesia or numbness or anesthesia here on that side. Pain is referred to the ear and pharynx as well. The patient will complain like the pain is being going to the ear as well and pharynx. Patient will present with these signs and symptoms. The It will be basically resembling the squamous cell carcinoma minus salivary gland neoplasm clinically and histologically. So this can come in exam as well. Necrotizing cell metaplasia resembles squamous cell carcinoma on the or minus salivary gland neoplasm clinically and histologically. So you do remember that necrotizing sialometaplasia resembles it. Then we have diagnosis. It could done like clinically. It clinically include rapid appearance of painful lesions and subsequent healing as well, because it is self-limiting and it resolves on its own and it will heal also very well could. Then we do treatment with the help the like it will resolve on its own without treatment in 6 to 10 weeks. Do remember the duration because it is self-limiting and it will resolve on its own in the 6 to 10 weeks. The recurrence rate is very much rare. So differential diagnosis basically can include like major aphthous ulcer. You can confuse it with, or there will be differential diagnosis. There could be a tertiary syphilis because in tertiary syphilis, and there is also a deep crater which is being formed on the palate as well. There could be traumatic ulceration and carcinoma squamous cells or salivary gland, as I told you earlier. So these are differentials. Now talking of the idiopathic disease, idiopathic disease includes chalothiasis, Salosis, basically, which is a non-inflammatory, non-neoplastic swelling of parotid bilaterally. The contributing factors are diabetics, alcohol, drugs, iodine, phenylbutazone, and neomarcazole. The treatment includes no treatment is basically required. This is a clinical picture of cirrhosis. So again, it is basically a non-inflammatory. It is not an inflammatory condition. It is non-neoplastic. It is not a malignant condition of the parotid gland bilaterally. Basically, swelling of bilaterally. Contributing factor includes diabetic. The causes can be either diabetic, alcohol, or drugs, iodine, these drugs. And treatment, there is no treatment required. Basically, it is also self-resolving. There is a bilateral swelling you can see in the parotid gland. And the thing you need to remember is basically non-inflammatory and non-neoplastic. So this was all about our today's lecture. I hope so. You guys got it. And thanks for listening. And inshallah, I will be back with another uh, important and useful lecture. Till then, stay tuned. Do subscribe my YouTube channel if you haven't, and watch all other videos as well. Thank you very much. Khuda Hafiz.